All right, let's dive straight into this high-stakes explainer on the clinical principles of ARDS and respiratory management. We are completely bypassing the basics today. Instead, we're going to directly test your critical care reflexes using some real, hard-hitting case scenarios. Let's get right to it.
Here's your first scenario. In all of the following conditions, a pulse oximeter may give you an inaccurate reading, except: is it A, carbon monoxide poisoning, B, methemoglobinemia, C, nail polish, D, hyperbilirubinemia, or E, deep pigmented skin? Take a second and lock in your answer.
And the answer is D, hyperbilirubinemia. Now, the mechanism here is absolutely crucial for your daily clinical practice. See, pulse oximeters calculate functional oxygen saturation using very specific red and infrared light wavelengths. Severe jaundice or high serum bilirubin simply doesn't interfere with the transmission or absorption of those specific wavelengths at all. But look closely at the clinical pearls here, because this is vital. Carbon monoxide poisoning, it fatally tricks the monitor. Carboxyhemoglobin absorbs light exactly like regular oxyhemoglobin, so it's going to give you a falsely normal reading even when your patient is severely toxic. And methemoglobinemia? That one literally locks the light absorption ratio. It basically forces the pulse ox to spit out a fixed reading of around 85%, and that happens regardless of what the true oxygen saturation actually is.
Okay, next question. A post-op patient receiving a massive 70% oxygen delivery has an ABG showing a pH of 7.48, a PO2 of just 55 millimeters of mercury, and a PCO2 of 30. So what's the diagnosis? A, COPD, B, post-op pain and anxiety, C, ARDS, D, post-op atelectasis, or E, none of the above. Really notice the refractory hypoxemia here, especially despite that massive fraction of inspired oxygen. The correct diagnosis is C, Adult Respiratory Distress Syndrome, or ARDS. Let's authoritatively break down the Berlin criteria for a second. To formally diagnose ARDS, you need an acute onset within 1 week, bilateral infiltrates on the chest X-ray, and, this is key, you must exclude cardiogenic edema. That's exactly why the pulmonary capillary wedge pressure needs to be under 18 millimeters of mercury. But the true defining feature, severe hypoxemia. You calculate that PO2/FiO2 ratio. So in our patient's case, a PO2 of 55 divided by an FiO2 of 0.70, that gives us a severely low ratio of 78. Since anything less than 300 confirms ARDS, a score of 78, yeah, that is profound. Building on that exact pathophysiology, which of the following abnormalities is most likely associated with ARDS? A, hypoxemia. B, decreased dead space. C, increased residual volume. D, increased compliance. Or E, increased FEV1.
The answer is A, hypoxemia. The fundamental physiologic hallmark of this entire pulmonary syndrome is refractory hypoxemia, and it's driven by widespread intrapulmonary shunting. Think about the physical mechanics here. As protein-rich inflammatory fluid just floods the alveoli, those structures undergo a massive diffuse collapse. So venous blood flows through the pulmonary capillaries, but it completely bypasses these flooded, non-functioning alveoli. It just returns to the systemic circulation without picking up any oxygen at all. And this brilliantly illustrates why compliance actually decreases. The lungs get incredibly stiff due to surfactant loss, and the functional residual capacity just severely drops off.
Now, looking at etiology, if you're asked which factor is least likely involved in ARDS prevention, but is actually its most common clinical association, the answer is sepsis. Systemic sepsis is an indirect trigger, obviously not a preventative measure, and it accounts for over 40% of all ARDS cases. Gram-negative bacteremia is usually the main suspect here. Those circulating bacterial endotoxins literally spark a widespread inflammatory cascade that directly damages the pulmonary capillary endothelium. Meanwhile, direct triggers include things like gastric aspiration, which makes up over 30% of cases.
So the crucial question becomes, how do we treat it when a patient actually deteriorates? Let's say a patient with acute severe pancreatitis develops ARDS. What will be your management strategy? A, 100% oxygen. B, endotracheal intubation and positive pressure ventilation. C, IV antibiotics. D, nebulization. Or E, IV steroids.
The correct strategy is B. This is your critical care management pathway. endotracheal intubation and mechanical positive pressure ventilation, combined with high PEEP. Honestly, PEEP is mechanically brilliant. It maintains a positive pressure baseline right at the end of expiration, effectively splinting those fluid-logged airways open. This recruits collapsed alveoli right back into the gas exchange game. But listen, you absolutely must adhere strictly to a lung protective strategy. You have to use low tidal volumes, we're talking just 6 milliliters per kilogram of ideal body weight, to avoid volume trauma, and you must keep those plateau pressures below 30 centimeters of water.
Okay, let's consider an immediate, life-threatening airway obstruction. A 72-year-old man with altered sensorium aspirates a large amount of gastric contents during intubation following a high-speed collision. What is the appropriate initial treatment? A. Bronchoscopy for particulate matter. B. Steroids. C. Prophylactic antibiotics. D. Inhaled nitric oxide. Or E. High PEEP.
The answer is A. When you're dealing with a gross macro aspiration that involves solid food particles, your dynamic mechanical action plan is paramount. Step 1. Immediately get the patient in a head-down Trendelenburg position. Step 2. Do thorough oral pharyngeal suctioning. Step 3. You need an urgent flexible bronchoscopy to directly visualize and clear that solid particulate matter right out of the tracheobronchial tree to prevent lobar obstruction. And let me be absolutely clear here, prophylactic antibiotics and systemic steroids are entirely useless right now. The initial reaction is a sterile chemical pneumonitis from the acid. It is not a bacterial infection.
Now, what about patients with neurological impairment? What is the most appropriate way to clear oropharyngeal and tracheal secretions in a patient who is unable to cough them up? A. Bronchoscopy. B. Tracheostomy. C. Atropine. D. Tracheal suction with a suction catheter. Or E. Stimulation of the pharynx.
The answer is D. Utilizing a sterile plastic tracheal suction catheter is simply the most effective, least invasive, and immediate method to restore airway patency and clear out those pooled secretions that threaten microaspiration. But heed this very stern clinical warning. You must limit individual suction passes to exactly 10 to 15 seconds. If you do prolonged passes, you literally pull oxygen straight out of the airway. That causes precipitous hypoxemia, and it can trigger a severe vaguely mediated bradycardia.
To really reinforce that macroaspiration protocol, let's look at this. Which of the following is the best option for treatment of pulmonary aspiration? A. IV steroids. B. Intubation and suctioning. C. IV broad-spectrum antibiotics. D. Antacids. Or E. Normal saline lavage.
It's B again, rapid intubation and direct airway suctioning. You have to mechanically pull that material out before it has the chance to migrate deeper into the peripheral lungs. And look at this pearl, because this is a dangerous clinical pitfall you absolutely must avoid. Never lavage the trachea with normal saline. It does not neutralize the acid. All it does is wash those acidic fluids even deeper into the peripheral alveoli, which severely compounds the injury. And again, hold off on those broad-spectrum antibiotics unless there is a very high initial risk of anaerobic contamination.
All right, moving on to the mechanics of spontaneous versus controlled ventilation. Which mode of ventilation provides positive pressure at the end of expiration in a spontaneously breathing patient? A. PCV. B. CMV. C. SIMV. D. CPAP. Or E. PEEP. The correct answer is D. CPAP. Let's quickly contrast CPAP and PEEP because while they function identically by splinting open collapsing alveoli, their actual application is totally different. CPAP, or continuous positive airway pressure, is a standalone support mode. It delivers continuous pressure to a patient who is actively maintaining their own respiratory drive. PEEP, on the other hand, is merely a baseline pressure adjunct. It's something you add directly onto a machine-controlled ventilation mode. Think of it this way. CPAP is the mode, PEEP is the setting. So, keeping that distinction in mind, in which mode is a preset volume and pressure delivered to a sedated, paralyzed patient on a ventilator? A. PCV. B. CVMV. C. SIMV. D. CPAP. Or E. PEP? Answer B. Controlled mandatory ventilation, or CMV. This is the fully assistive classic ventilator mode that takes complete control over the patient. Because the machine strictly dictates the entire breathing cycle regardless of any active effort from the patient, absolute deep sedation or muscle relaxation is a total necessity. If they aren't properly sedated, they're going to fight the ventilator, and that causes incredibly dangerous spikes in peak airway pressures. This carries a massive barotrauma risk, particularly for patients with poor lung compliance, morbid obesity, or those placed in a head-down Trendelenburg position for surgery.
Now, let's explore the critical and frankly often overlooked hemodynamic consequences of elevated intrathoracic pressure. Which of the following is the initial side effect of positive end expiratory pressure, or PEEP? A. Hypotension. B. Hypertension. C. Cardiac tamponade. D. Raised JVP. Or E. Increased return to the heart.
The initial side effect is D, raised jugular venous pressure. Let's unpack this mechanical cascade because it's fascinating. Introducing PEEP elevates your intrathoracic pressure. This directly increases right atrial pressure, which then impedes normal systemic venous return. So blood pools upstream in the vena cava system, and that presents visibly as a raised JVP. From there, the reduction in venous return drops your right ventricular preload. The high alveolar pressure can then dilate the right ventricle, which physically bows the septum right into the left ventricle. This restricts left ventricular filling, lowers stroke volume, and ultimately drives dangerous systemic hypotension. Basically, what starts in the lungs heavily dictates the heart.
Focusing finally on systemic toxicity, which of the following is true regarding local anesthesia? A. 2 mL contains 10% lignocaine. B. Cardiotoxicity is the main adverse effect. C. May cause convulsions/seizures. D. Lignocaine action is delayed if epinephrine is added. Or E. None of the above.
The answer is C. Local anesthetic systemic toxicity, or LAST, occurs when high plasma levels cross the blood-brain barrier, and the chilling part here is that it selectively blocks your inhibitory CNS pathways first. That unleashes unopposed excitatory activity, which triggers severe tonic-clonic convulsions or seizures. And I want to leave you with two high-stakes clinical pearls to end on. First, bupivacaine overdose binds incredibly tightly to cardiac sodium channels, causing sudden treatment-resistant cardiac arrest. Meanwhile, prilocaine overdose actually converts native hemoglobin into methemoglobin. That creates the exact same methemoglobinemia that fatally tricks your pulse oximeter readings, which is exactly what we talked about in the very first question today. How's that for a full circle moment? You've seen how pulmonary mechanics and systemic toxicity interlock perfectly. But what other hidden physiological traps are waiting in your next code blue? Stay sharp out there, keep investigating, and always respect the physiology.